Well, thank you very much. I appreciate the opportunity to be here. My name is McCracken. I'm a neurosurgeon in Piedmont Hospital System in Atlanta, Georgia. And today we're going to talk about GammaTile brachytherapy in the upfront treatment of GBM. We have used this quite a bit in all tumor types we'll talk about in the upfront role. There are my disclosures. So for those of you who don't know, GammaTile is an FDA-cleared product that was initially cleared in 2018 for recurrent types of malignancies, and then in 2019 was cleared for the upfront treatment of newly diagnosed malignant brain tumors. It is a brachytherapy similar to a stranded seed brachytherapy, which uses 4 separate cesium-131 radiation sources. And these are placed immediately within a resection cavity after a tumor has been removed. The spacing of this actually prevents hot and cold spots when you place them, which has been some of the criticism for stranded seeds. And then over time, the body naturally absorbs these Duragen tiles, but the small titanium seeds are actually left behind in place. And so these are made from a bioresorbable collagen implant. You can see here on the schematic diagram that seeds are actually structurally offset. So when you place them in, there's actually a 3-millimeter offset from the middle of the tile, so that you actually get a very even dose distribution from when you place these against the subcortical white matter. And the way these are designed is that they are designed after at least 3 tiles are implanted to give an approximate 60 gray dose of radiation to a depth of 5 millimeters within the tissue. They have about a 10-day half-life, so approximately 6 to 7 weeks, almost all the radiation's been delivered. And so really, if you think about it, within the first 10 days, 50% of the dose has been delivered, which is pretty amazing. You can see here on the dose distribution line between the clinical target volume and from where the tiles are laid, that the vast majority of the radiation is delivered up to 5 or 6 millimeters from where these tiles are laid. And the reason why we started looking at this and GT Medical started looking at this for the upfront treatment of GBM is really this notion of rapid early progression. And there was a paper which came out in 2022 talking about the incidence and rate of rapid early progression. And what they found is that over many studies, approximately 45% of patients have some degree of progression from the time of surgical resection to when they start their Stoop protocol external beam radiation. And certainly this is more common after somebody who's had a subtotal resection and if they have a wild type of GBM. And as you can imagine, this rapid early progression is certainly associated with worse overall survival, worse progression-free survival, and certainly affects the long-term outcome of these patients. And this was the meta-analysis. And just to go show you an example, so this is actually one of my patients. So preoperatively, this was a 41-year-old gentleman who came in with this large left sort of insular GBM. He was already hemiparetic on the right, having aphasia. And this is a guy that, we know is going to have to go to rehab. There's probably going to be a delay in, his adjuvant therapy. And so despite the fact that we actually got a very nice resection, this guy goes to rehab at the Shepherd Center down in Atlanta where we are. And certainly there's a delay. We can't, especially in the state of Georgia, we can't go back and forth to, getting radiation therapy. They can't start chemotherapy. And so at 6 weeks later, we get a phone call. This guy's progressively getting worse, and we rescan him, and this is what this looks like. And so this is a very common story. We see this all the time. And so this guy, even though we tried to do emergent salvage radiation, he goes on to die 2 months later. And so the concept of treating early sort of came about. And so right now there is a feasibility study going on called the Gestalt clinical trial. And it's actually not a clinical trial, it's a feasibility study to prove, can we safely deliver in patients who are newly diagnosed with GBM? Can we safely get them through resection and implantation of GammaTile and then onto an abbreviated form of the Stoop protocol? And so the way this is designed is there's actually 61 patients who are looking to be enrolled across 15 sites. Patients, once they are enrolled, go on to receive hopefully a gross total or near total resection. They go on to get implantation of GammaTile, which basically serves as the high dose boost to the resection cavity. and then they go on to receive a 4-week course of radiation. So as opposed to 6 weeks at 60 gray, they go on to receive 4 weeks at 46 gray to the surrounding flare signal, and the GammaTiles actually serve as the boost to the resection cavity. They still go on to get adjuvant temozolomide for the first 6 weeks, and then the metronomic temozolomide over the next 6 months, and that's the way the trial is designed. Basically, the study aim is to look at, can we do this safely? What are the potential surgical complications? And the primary endpoint is, can we get them to adjuvant external beam within the 21 to 35 days postoperatively? There are multiple other aims with respect to safety, adverse events, and then certainly overall survival, progression-free survival, et cetera. And so this is our first patient. This gentleman was actually treated in September of 2022. And so he enrolled, actually has a very resectable, straightforward GBM, I think for the most of us. He's got this sort of posterior right temporal occipital GBM that we were able to get a nice gross total resection on. To give you an idea about what the postoperative dosimetry looks like, the bottom screens will actually show you that red isodose line is actually the 60 gray isodose line. So you will actually get more dose fall off beyond that, between 20 and 10, et cetera. But that's what the resection cavity looks like, and that's what the high dose treatment's going to look like. This is just another picture showing you in multiple directions what these pictures look like. And then from a radiation planning, it's actually a little bit complicated for the radiation oncologist and the dosimetrist, but ultimately they have to split the radiation dose into a high dose and a low dose radiation treatment. And so the high dose, as I told you, is treated by the tiles, and then a 46 gray dose is delivered in a donut hole fashion to the surrounding flare signal. And amazingly, this is follow-up for this gentleman. So he is now 20 months out, and I'm not saying every patient looks like this, but this is now 20 months out, and he has yet to have a recurrence. As you look down there, his last MRI is March of 2024. He has never gone on to receive any other adjuvant therapy beyond sort of the 6 months of temozolomide. Not all of our patients have looked like this, but this is just to show you, I think, the power of sort of early treatment, just like Dr. McDermott mentioned, getting these patients treatment as early as possible, whether it be chemotherapy, immunotherapy, or radiation. This is another example of somebody who we don't get a gross total resection on, but how the planning looks and how we ultimately treat these patients. So this is obviously a complex right sort of frontal parietal tumor. We actually had to leave a small cuff of tumor behind along the cortical spinal tract. You can see that small area of contrast enhancement. That can actually be treated with external beam in the post-planning treatment period. But this just goes to show you, what a powerful surgery can do, and then what our postoperative planning looks like. This is the schema that everybody gets from a physicist and dosimetry standpoint to show how small residuals can be treated. And so these are basically split into the high dose area, and then what would be residual be treated with the external beam. And so even though it's a complex set of pictures, it's just to show you that even if you have to leave some behind, this still can be treated within the context of the clinical trial. And so this is our first 8 patients. We actually have another patient who's going for surgery on Monday next week. And ultimately, a lot of this is still going to be dependent on MGMT and IDH status. Obviously, that first patient is up to 22 months with stable disease. Our second patient, she actually passed away at 16 months after a progression. The only other person that had a progression that actually turned out to be radiation necrosis was our third patient. We took him back for repeat surgical resection. Our pathologists are really excellent at sort of quantifying what's necrosis, what's recurrent disease. And this gentleman basically had 95% necrosis, which was cleaned out. And then he did not go on to any other adjuvant therapy, and he's doing well at 15 months. So we have a lot of other patients who are sort of in the throes of their timeline. Some patients who are 13 months out, 9 months out, 5.5 months out. And so it'll be very interesting to see how these patients ultimately do long term. I also want to talk about a separate niche set of patients that necessarily don't fit into a clinical trial or not going to be clinical trial candidates. These are typically patients who are elderly or have significant neurological deficits upon admission. These are the patients that I think should seriously be considered for use of this brachytherapy in the upfront setting, because these are the patients that are going to go to rehab, that are going to have a significant delay in their care. And so this is a 82-year-old patient who came in, very similar to that first patient. She's got this left frontal insular tumor, densely hemiparetic on the right, aphasic, obviously going to have to go to rehab, is never going to be a clinical trial candidate. So the family still wanted to be aggressive. So we get a nice surgical resection, and then she goes on to get rehab for 6 weeks. You can see her follow-up scan on September 15th, which is 6.5 weeks after her surgical resection. It still looks like her postoperative scan, and all she's gotten is just the GammaTile. She never had any sort of adjuvant therapy. At that point, she had recovered well enough to be able to get some form of adjuvant therapy. She goes on to get this abbreviated form of radiation, and ultimately lives for about 12 months. And so we have a separate set of patients that are sort of in this same category that I think are, that are probably going to die within several months if you do nothing or just do a surgical resection. So this is another patient who, actually a 29-year-old, history of grade 2 astrocytoma in 2015, who progressed. You can see here she's got this very large right parietal GBM. We go on to give her resection plus GammaTile. She was a very difficult person to follow up with. She didn't want adjuvant chemotherapy. And so the cavity was actually very well controlled. This is actually a scan from about a week ago on the bottom. You can see the cavity is very well controlled without any sort of adjuvant therapy, but she did progress in the far right frontal lobe. And so we're going to have to discuss how to treat her with that. But the cavity itself is actually well controlled without any other sort of chemo or radiation. So we have 7 patients that we've treated sort of in this fashion. These are patients who've either had a significant delay in their adjuvant therapy. And the way we look at these patients are, these are patients who are tremendously sick, who are never going to be candidates for other type of therapy. And potentially we're giving them another 6, 9, 12 months to live, when maybe they would have died within weeks or several months. And so I think it's certainly something to consider when these patients come into your hospital sort of in this extremist or urgent fashion. So in conclusion, I do think the addition of brachytherapy for new GBM, it does allow for the immediate treatment of residual tumors within the cavity, providing that you can get either a, gross total or near total resection. And I do think that it does prevent this notion of rapid early progression. In our initial set of our clinical trial patients, the time to recurrence appears to be delayed than sort of the standard of care, which we've used forever. But I think this is also very much dependent on their IDH and MGMT status as well. In patients where there is going to be a delay, those sort of urgent or extreme patients, I do think that the placement of GammaTile provides a means for giving them treatment in the upfront setting until they are well enough to receive some form of external beam or chemotherapy. And I think at the completion of the Gestalt feasibility study, I think there are approximately 60 to 70% enrolled at this point, will likely lead to a full-blown randomized clinical trial. So it'll be interesting to see how that goes as well. So with that, I'll conclude and certainly take any questions if anybody has any.
Great talk. It looked like in your trial patients, you reoperated on one patient.
Correct.
Is there any difference in going back in terms of scarring or adhesions or challenges compared to conventional reoperations?
No, that's a great question. I think, obviously the seeds are there. So even though they're inert at that point, right? So all the radiation is gone, within about a month and a half. We still try to make sure we get all the titanium seeds out. But most of the time it just looks like cheesy necrotic material.
Mm-hmm.
And so even though, and that's one of the things that I think we've had to learn on follow-up imaging is that, this truly makes these MRIs look more different than you would expect. And so some of the experience that we've learned is to try to figure out, is this true progression? Is it necrosis? Is it pseudoprogression? Whatever it may be. And so part of the reason that we went back and operated on this gentleman was that we presumed this had just completely progressed. And then you get in there and you remove it, it's necrotic, and pathology confirms it's all necrosis. So it's no different than treating a radiation necrosis patient. Yeah.
Thank you. Any other questions?
Yes.
Yeah, nice talk. I wonder when you look at your MGMT unmethylated group, in this day and age, as Annalise nicely put it, we're going to know in the OR what we're dealing with, right?
Yeah.
So if we find out it's MGMT unmethylated, that may be a nice option, as we get some of this data out there.
I think you're absolutely right. I mean, I think that it's actually really exciting to hear about some of the, the new things coming out where you can figure out sort of the molecular and genetic status, even, at your frozen pathology. I mean, that's tremendous. I think you have to be, either have, if you're going to use potentially tiles or not, I think you have to have those ready to be able to implant. So if you're going to make that decision, yeah, absolutely. And there is some, for those of you who haven't used it, there are some logistics with respect to estimating the number of tiles you're going to use within the cavity, ordering them, having the physics team bring them up. And so there are some logistics. And so, having that streamlined is going to be key. So.
Yeah, excellent talk. I've used GammaTiles for the last 2 years with favorable results. Have you had any pushback from radiation oncologists about upfront treatment or reduced doses for them? And second thing, have you had any migration?
That's a great question. I think the pushback we got initially was from the neuro-oncologist. And I think the concern is that using this in a sort of non-standard fashion, you're not using it in the Stupe protocol, it's going to exclude patients from clinical trials, in the recurrent setting, right? That was their biggest concern. But I feel like, through the feasibility study, with a proper IRB, they've been much more, okay using it in that setting. But not the radiation oncologists. The radiation oncologists have actually been very supportive of it. From a migration setting, I've seen it once, and that was in a patient who, it was a left frontal lesion that we opened into the ventricle, and that happened approximately 6 months later. So you could actually see the seeds within whether it MRI or CT, and then 6 months later, he came back in, all the seeds were gone. We scanned him from head to toe, and they had all basically migrated into the thecal sac. So we found mostly all the seeds sort of in the sacrum and in the thoracic spine. At that point, of course, they're inert. They're not going to cause any trouble, but they can migrate, just like prostate seeds migrate to the lungs, But as long as they're inert, and typically they won't migrate until the duragen breaks down, which is probably 6 months later. Yeah.
Dr. Rodriguez?
Yes, so great talk. I'm very much interested in the Gestalt trial. Can you talk a little bit about you said gross total or near total resection? Can you talk about what the near total, how is that defined in this feasibility trial? And then secondly, does it warrant intraoperative MRI to confirm the level of quote unquote near total? Can you just expand on that?
Yeah, I think part of that is because sort of the depth of penetration of the radiation is only going to reach so far, right? So, if the goal is to achieve a 60 gray, basically treatment to that depth, if you leave a large portion of tumor behind, whether it's 5 millimeters, 1 centimeter, et cetera, you're not going to get that same dose. In the patient that I showed where we had to leave some against sort of the cortical spinal tract, within the context of the trial, that can be treated with external beam. That can be sort of covered, within the external beam trial. So, I think within the context of the trial, it's not specifically dictated what is near total resection, whether it's a volume or a size. That's more something that, we go over with the dosimetrist and the radiation oncologist later to figure out how much is, treatable by external beam versus the actual tiles. Yeah. Yes, sir.
I would like to take the fifth on how long I've been doing brachytherapy for, but we went through a lot of trials that use CSF, different isotope. I think there's an advantage for cesium, but one of the things I think you should do in this trial is if it's a registry, you should probably, I like the idea of carving out the IMRT treatment to limit the dose, but you should definitely look at the BED equivalent on these patients, because in the upfront trial that we did with iodine, granted different isotope, longer half-life, the toxicity was limiting, and so that's what stopped us.
Yeah, I think that's why cesium was chosen for that same reason. But you're right. So a lot of work went into looking at the bioequivalent dose, and so between the 46 gray that's delivered sort of that low risk area, combined with the high risk cavity, that is designed to achieve a bioequivalent dose to what you would achieve with Stoop. Yeah.
Jose?
Thank you very much for your talk. Great talk about the brachytherapy and what it can bring for our patients. I would like to pick up on that case that you showed a little bit of residual in the cortical spinal tract to see if when you're planning the position of the tiles, if you have in consideration function, eloquent margins that you left in your tumor resection, and if there is any type of calculation with your physicists to limit the dose for eloquent cortical and subcortical areas.
Yeah, I think two things on that. So when we are planning, I do think the neurosurgeons have to be involved in the planning. I don't think we can just give that up to the radiation oncologist because, you know, we are the only ones who are going to know what our plan is going to be, how much cortex you're going to take, what approach you're going to take. And so I think we have to be involved with the tile, you know, with the estimate planning. Are you going to take a lot of cortex? Are you not? Whatever it may be. You know, there is always a contraction built into the calculations for how much, you know, tiles you're going to use. I think what changes is if you are going to use things like Glealan, you know, because that actually allows you more of a super maximal resection that you sometimes can't take into account when you're doing the tile planning. So if I'm going to use 5-ALA or fluorescence, whatever it may be, I typically won't put in the contraction for the tile estimation because we know we're going to probably use more than what the typical estimate would use. If we are planning on potentially leaving some residual, we do take that into account. But if it's going to be a significant residual, you know, that may not be a patient that we use the tiles on. So I'm okay with the small, you know, sort of small area residual that we will still tile sort of in the same fashion. But yeah.
This is a great talk, Jay. Very interesting technology there. Quick question for you. Indications or use in other intracranial tumors, atypical, you know, grade 2, grade 3 meningiomas at the skull base, or any other experience with that?
Yeah, so we've used it in all tumor types. We've used it in upfront and recurrent GBM, upfront and recurrent brain metastases. And then we've used it in recurrent atypical and malignant meningioma. So, and there's great data that's coming out from, especially in the recurrent metastases standpoint, Memorial Sloan Kettering, Miami Cancer Institute, showing that the rate of local control after recurrent METs is tremendously high, 92 to 100% in multiple different studies. In recurrent atypical and malignant meningiomas, especially those that have not received radiation prior, the rate of local control is tremendously high. Okay, so we've used it in sort of all, you know, tumor tissue types. I will say though that in patients who have received some form of radiation therapy previously, whether it's a GBM, a MET, et cetera, the rate of potential radiation necrosis does go up, right? Especially in somebody who has potentially received 60 gray initially, and then a year later you're going back and you're giving them another dose of 60 gray. You know, I think the radiation necrosis rates are approximately 10 to 15%, but you do have to watch those patients very carefully.